Okay, so welcome back in our course on bioethics in the Masters of Cell and Molecular Biology at St. Thomas University. We're making the shift now towards healthcare bioethics, okay? And after talking about these three basic principles that we used in bioethics on the sources of the ethical act, and then the principle of double effect and cooperation with evil. Now we're going to see some applications, particularly with double effect, which is a very, very handy principle that we use in bioethics. And you see the application on today's lecture. So we're going to be covering two aspects in healthcare bioethics today. Excuse me. One will be cancers of the reproductive organs, and the other one is ectopic pregnancy. Now, I'm singling out cancers of the reproductive organs because, in contrast to any other cancer, you know that cancer has to do with the tissue that it's invading, even before it metastasized, wherever it's found in whatever organ or tissue. And of course, it's a vital organ, then it's bad news. But a couple of things. We know that the reproductive organs, as important as they are, they're not vital organs. And therefore, cancer of the reproductive organs, in principle, can be cured. The typical protocol is to surgery to remove the organs. Okay. However, the other aspect is that the reproductive organs have kind of a double ethics to them because they belong to each individual, but they also belong to the next generation. So there's a certain double responsibility there toward the reproductive organs in the sense that they also belong to the next generation. That's how naturally we procreate. And therefore, reproductive organs should not be mutilated without a serious reason, okay? And that's why the principle of double effect will apply typically when there is cancer. All right, and then in the second half of the lecture, I'll look at ectopic pregnancy. So again, if you have any questions or comments at any point, just step in, okay? Right. So just to review double effect, which is the main one that we're going to be using today. Remember that we have two simultaneous effects generating from the same single act, all right? That's crucial. They're not sequential, they're simultaneous. And one is a good effect, another one is a bad effect, ethically speaking, negatively. And the conditions that we go through for double effect to apply, all right? First, the act itself must be morally good or indifferent. This has to do with the moral object. Precisely, that's why I covered the fonts of morality, because number one here, the first condition is that the act in itself is either good or neutral, ethically speaking. So that has to do with the moral or ethical object, right? Secondly, so in other words, it's not an intrinsic evil. Second one is that the good effect must flow simultaneously, but not be obtained through the evil effect. Right. So again, it's double effect. So the good effect does not depend on the evil effect for it to occur. The third one has to do with the intentionality, which we talked about is subjective, and yet there are good intentions and bad intentions. So in double effect, the evil effect should not be willed, tolerated because it's inevitable, all right, but not desired as such. The fourth condition, proportionality, so it's something serious seriousness for seriousness on the procedure and the protocol. And obviously that there is no other protocol or procedure that does not have a bad effect flowing simultaneously. All right, let's move forward then. In men, the two main cancers of the reproductive organ are either testicular cancer or prostate cancer, okay? Different, and not gonna dwell too much. Testicular cancer, again, the standard protocol is surgery to excise one or both testicles, depending. They go one by one, but if it has spread already, then both testicles need to be excised. And obviously that's going to render the man infertile. Prostate cancer is a little different. And so the good thing about testicular cancer is that it's pretty rare in general. However, for men between 18 and 35, it's the most common type of cancer. Okay, so it's kind of paradoxical. For young people, young adults, it's the most common type of cancer, which means that in general, all cancers are rare for young people in general, but for men, it is. And it may have to do, again, with development of testosterone, which is a pretty strong hormone. Anyway, the protocol is to excise the testicles. Prostate cancer is different. Prostate cancer, first, let's look at the gland itself, because the gland it sits basically at the base of the abdominal region underneath the bladder. Here's the bladder. There's a cross section, all right? Here's the bladder. Here's the rectum. And this is the bone, the pubic bone around the hip. Here is the coccyx. All right, so you follow the anatomy. It's innervated. So this is the prostate. It sits at the base of the bladder. And the prostate has two functions. It's a gland, only in males. And it has two functions. It makes semen, which is the fluid that maintains sperm alive, and it's nutrient for the sperm and also lubricant. But it's also, the prostate is also involved in the erectile function. And therefore, for prostate cancer, typically for cancers, the idea is to remove the cancerous tissue, right? So prostate is a concern depending on what is known as the social history of the individual. If they're married, if the man is married or not, it makes a difference, right? So it's a little delicate that way. And it's a tougher decision for men who are married because of the consequences, the implications of removing the prostate. And however, you know, the prostate cancer is the #1 cancer killer of men. It is equivalent to breast cancer in women, all right? And so it has to be taken seriously. But prostate cancer typically develops later in life, after 50s, more or less, in the 50s. They check for the PSA. PSA is an antigen, a protein. The PSA level, right? So prostate-specific antigen is in the bloodstream only of men. And what the doctor does with the annual, that's what the annual checkup is very important, because they'll follow the PSA. That should be very low. If the PSA starts rising, then it may be an indication that the prostate is developing cancer, or at least what is known as neoplastic cells. Neoplastic cells are precursors to the actual cancer. So they check for the PSA level. If the PSA is a little high, then the next step in the protocol is to do a biopsy of the prostate. It's a rectal biopsy. They go in with a tube here, and they pull out about a dozen samples through the prostate, sent to the lab for analysis. And if they show neoplastic, then that means they are precursors. Neoplastic cells can either arrest or they can progress into cancer cells, all right? So there's no other symptom generally, not too many other symptoms. There's no pain or anything like that. Sometimes it could be difficult to urinating because it constricts. So the prostate has two sphincters, one above and one below, that control the bladder, all right? But by the time they constrain the urethra, which is what connects the bladder to the outside, then that means that the prostate is already quite inflamed, all right? It's a little too late. So all cancers, applies to all cancers, you want to catch them as soon as possible. And the very few symptoms, and that's why I insist that women should have also their annual checkup at least once a year and follow the blood work. So here is double effect is removing an organ. The organ is pathological and it has consequences. The consequences are not desired, but they're tolerated. They have to be tolerated. The alternative is to let the cancer progress. And I've known a number of men who have died from prostate cancer because they didn't want to get tested or they didn't want to follow up in the protocol that was important. And once it metastasizes, it typically metastasizes to the bone, to the hip. And then we got bone cancer. So it's not a good set, okay? It can be caught early on, and that's when it's the time to act. Now there are other procedures that are getting very creative, trying to preserve the function of the prostate, so not have to excise it. One technique is to freeze it. Another one is to put radio pellets, isotope pellets, to radiate the cancerous cells and try to kill them that way. But the most effective one is what is known as a prostatectomy, which is the removal of the gland itself. Yeah, I think they use liquid nitrogen, actually go in with tiny tubes and try to freeze the tissue and kill it that way. Freezing and killing the cancerous, the tumor. Okay. But trying to preserve the gland as a whole. My opinion is risky, but people have to make their decisions. At least if this is a type of cancer in men that develops later in life after 50s. So generally, most marriages have had their children by the time they're in their 50s and so forth. So at least they've had their children if they were going to have them. Again, because it will render the person infertile and impotent also. To remove the prostate. Okay, so you can see how double effect applies here. In women, the cancer of reproductive organs in women is called gynecological cancer. All right, there are 5 different gynecological cancers, actually 6, which would be on the fallopian tubes, but very, very rare. These are the 3 main ones, and then 2 more would be vaginal cancer and vulval cancer, but they're not that common. These are the most common gynecological cancers, all right? Ovarian, uterine, and cervical. And the protocol, the indication is to remove those organs, again, rendering the woman infertile. So it's a serious decision, but again, you got life for health, right? And so you can see how double effect applies. All of these procedures will render the woman infertile. That's the bad effect. It's not desired, but it's tolerated. It's like to save the health and the life of the mother.
Even if someone in theory keeps their reproductive viability, it doesn't really matter if the cancer goes on.
Yes, exactly. So the one that could be an exception here is ovarian cancer, because if it's not bilateral, then they can remove the one pathological ovary. Hopefully, if it's caught early on, okay, and it has not metastasized, then they will preserve the other one. Some women, when they get ovarian cancer on one ovary, they want to have a full hysterectomy and remove all the reproductive organs as prophylaxis, all right? And it can be accepted even though the other ovary is still healthy, but you only need one cell really to escape, one cancerous cell to escape and invade the tissue to start the cancer again. And therefore, as prophylaxis, it can be accepted, double effect applies. This one, at least there are more symptoms, because typically there will be abdominal pain and discomfort and sometimes bleeding and so forth, and it will interfere with the menstrual cycle. So at least there's some kind of warnings coming from gynecological cancers, okay? But they need to be addressed quickly. For any cancer, it's typically 4 stages, right? And the biopsy, what the biopsy does is they try to determine what stage it's at, and then that will determine the protocol to use the therapy. And many times, even after surgery, removal of the cancerous organ, they will still do a round of chemo or radiotherapy, more common chemotherapy. Okay, finally, the last one on the cancers is when the woman is pregnant and there's gynecological cancer. And now you get another individual involved, okay, which is the unborn. So even in this case, double effect does apply because what you have is that the reproductive organ itself is pathological. And so it justifies removing, and it's a serious pathology. We're not talking about acne or something like that. We're talking about cancer that can kill the woman. And therefore, it is foreseen that the embryo will die, or the fetus, not desired, not intended, but it has to be accepted, sadly, and it will be the loss of that pregnancy. Now, I also need to say that some women have been heroic in this aspect when they are pregnant and they find out that they have cancer of the reproductive organs, any one of these 3 main ones, and they forego the treatment, at least until the fetus is viable, which right now is around 22 to 23 weeks. I mean, they're little tiny preemies. All right, but the incubators have gotten so good, the neonatal ICU, the NICU, neonatal ICU units. So they can save from 21, 22 weeks forward, which is amazing. So halfway through the pregnancy only. But in the meantime, the cancer is progressing. So obviously, if they undergo treatment, let's say they don't go through through surgery, hysterectomy, but they would do a round of chemo, that will typically damage the embryo, right? And so they forego the chemo, advance the pregnancy until the fetus is viable, do a C-section, take out the fetus, and try to keep him or her alive in the NICU. And then she'll go through the treatment, but sometimes it's too late. It has metastasized, and it's too late. But anyway, this is a heroic measure on the part of the mother to save the life of her child, and it has happened, of course, is not obligated because double effect allows for the removal of the pathology. And there was a case in Italy a few years back. She was actually a gynecologist. She was a medical doctor, so she knew what was going on. Married, I think she had 2 children already. Her name is Gianna Molla. And Gianna was a very devout Catholic and decided to forego, so she became pregnant with the 3rd child and decided to forego chemo until her child was viable. These are the 2 that she had already, of course, they're born, and she's pregnant with the 3rd one. And they were able to save the baby. The baby lived. But, so here's a picture with the 3 of them, the 3 children. But she eventually died of cancer. She died of cancer. And because her action was heroic to save her child, she was promoted for the cause of beatification, and then canonization. And I think it was John Paul II, St. John Paul II, who gave the decree of canonization for her. Her husband and the 3 children were at the Vatican at St. Peter's Square participating in the canonization of their mother slash wife. Again, it's heroic. It's not required. It's not obligatory because double effect would have applied. But she decided to forego her life to give life to her 3rd child. And so she's kind of a patroness for the pro-life movement because of her heroic actions. And I've heard, just anecdotally, that she has inspired other women who have been pregnant and have developed gynecological cancer to also do the same. Again, it's a heroic measure. It's extraordinary, and therefore it's not obligatory for sure, but it's inspirational. Okay. All right. So again, you see how double effect is very, very handy. Of course, it's challenging and difficult for the couple or the mom because it's a wanted pregnancy, okay? But that pregnancy typically will be lost when they do the procedure.
Is there any survival rate for the embryo? Or is it usually just...
I don't know, but I think, well, of course, it depends on viability, right? If it's beyond viability, they try to save at that point it will be a fetus. After 8 weeks, we switch the name technically to fetus. But I know that at Baptist, Maine, here in Miami, a few years back, a baby who was 21 weeks in gestation was saved. So that's kind of the standard right now, 21 weeks. Okay. Now, the next topic here is ectopic pregnancy, which is a little different. Because in ectopic pregnancy, we have a different type of pathology, but it is a pathology, okay? And that's important because the pathology is what justifies the intervention, the surgical intervention. So in the previous part, I was talking about cancer. That's the pathology itself. And therefore, there is justification, there's ethical justification to remove the pathological organ because otherwise, as the cancer progresses, it can kill the mother, the man, or the woman. Here, the organs essentially are healthy, but the little embryo got stuck in the wrong place, got stuck in the fallopian tube. There are actually several different places where the embryo can get stuck. All of them are extrauterine because the uterus is the only organ that is naturally designed to hold the pregnancy. All right, the uterus, I mean, has to expand tremendously, become spongy, form the placenta, vascularize, and so there's a lot of demand on that tissue. On that, it's a smooth muscle, right? And the uterus is really the only organ that can sustain that naturally. But a little embryo can lodge in any number of places. Let's see. Look at this. Beginning with the ovary. In other words, here, what happened was the sperm went all the way through the tube and actually fertilized the egg that was rupturing, okay? But never really left the follicle. And so this is ovarian pregnancy, extremely dangerous, of course, because the ovary is not going to be able to sustain that pregnancy as the embryo starts growing. And the typical case is that the capillaries will burst and there's a massive hemorrhage. So beginning there, then on the fallopian tube, anywhere along the tube, horn or further down, proximal to the uterus. This is the normal place, uterine wall. Okay. Sometimes the embryo can lodge above on the ceiling of the uterus or in the cervix, wrong place. And there's a very rare case, which is the abdominal ectopic pregnancy, okay? This one, what happens here is that the embryo was actually, the egg was fertilized in the horn, in the ampulla, but then slipped out because remember that the fallopian tube is not attached directly to the ovary, all right? It's like a little glove and there's a thin gap there, but the embryo is at that stage, the blastocyst is about 10, 12 microns in diameter, certainly microscopic, and can slip out through that gap. And so very rarely, an embryo will come out here and lodge in the abdominal wall somewhere, typically around the intestines or the stomach, or, all right? Lower on the lower abdomen, and will start generating a placenta that will invade all that tissue. Now, we know that the abdominal region is highly vascularized because of absorption of food and so forth from the intestines, and also keeping the gut, keeping all the viscera alive. So a lot of vascularization, and the placenta will connect with those capillaries, those blood vessels, and establish. And very, very rarely you hear of a case where the abdominal pregnancy was actually saved. In other words, the embryo, the fetus grew to viability about halfway through the pregnancy, and the placenta continued to invade but did not rupture the vessels. And so the doctor, the surgeon, did a C-section and pulled out the fetus from the abdominal region. And some of those have been saved. Yeah, small. No, the whole embryo is growing there with the placenta, but it's outside the uterus. It's growing in the abdominal cavity, the abdominal region, around the intestines, around the stomach, behind the underneath the liver, you know, in the lower abdomen.
Oh, like as if it were like an extra organ or something like that.
Yeah, Exactly. Yeah. The key is that the placenta does not rupture the blood vessels of the mother, okay, or any of the vital organs, because then it's a very, very serious condition, of course, life-threatening. But a few of these abdominal pregnancies, which it's only about 1% I see here, a few of these abdominal pregnancies have actually been rescued, have survived, but extremely dangerous, all right? Very, very high risk. So in any of these situations, removal of the tissue, the pathology. Well, first of all, I want to say that the good news about ectopic pregnancy is that most of them actually resolve on their own, okay? They resolve on their own, meaning that combination of when the embryo is still small enough, between the peristaltic movement of the fallopian tube and the biochemistry of the mucus and the little hair-like structures that are inside the fallopian tube, manage to dislodge that little embryo and push it down, push him or her down. Now, it's hard to tell if that embryo is then going to attach in the proper place or not. Some may, others will just be discarded because they've died, okay? But the good thing about ectopic pregnancy, the typical ectopic pregnancy, which is most of it on the fallopian tube, is that they resolve on their own. That's a good thing. So they do this expectant attendant observation, just continue to monitor the mother. She will have pains on one side or the other. Just continue to monitor her and follow with ultrasound. If it does not resolve, then there has to be an intervention quickly because the fallopian tube is so tiny, it's not going to sustain that embryo growing very fast. Remember, 5,000 times the size, right? And therefore, it's going to rupture everything on its pathway. And then comes the decision which of the two basic procedures to perform, sapropingectomy or sapingostomy, right? And there is an ethical difference between the two. Sadly, the ethical difference goes against the clinical preference. So sapropingectomy involves removing the tube itself with the embryo inside, okay? And you notice that what is pathological? The tube has become pathological, the fallopian tube. And that's critical for the ethical analysis because now the fallopian tube has become pathological by having this embryo lodged in it. And therefore, the tube can be removed as a whole. The embryo is inside the tube, and it is foreseen that the embryo will die. But there's no direct intervention on the embryo himself or herself, okay? That's crucial for the ethical analysis. Sapingostomy is different. Sapingostomy is making an incision, typically a longitudinal incision on the tube, and scraping out the embryo directly. All right, so those are the two procedures. And the ethics is different. So let's look at sapropingectomy here for a moment. There are two types, total or partial. Total is this one where the tube is removed from the proximal end near the uterus and excised, and this whole tube that has become pathological because of the ectopic pregnancy now becomes medical waste. It will go into a red bag with a biohazard sign and typically incinerated at the end of the day in the hospital, okay, where the procedure is being done. Partial is to remove just the section of the tube that is pathological, where the embryo is lodged, but not remove the embryo directly, not intervene with the embryo directly, rather just cut out the tube, the section of the tube where the embryo is lodged. Advantages and disadvantages. For the reproductive health of the mother, a total sapingectomy cuts her reproductive chances to 50%, assuming that the other tube is fine. Okay. So it reduces her pregnancy possibilities to half, but the other tube may be healthy, and so she's not rendered infertile. This one, what's the desire here? It's not shown in this diagram, but what would be after excising just a little segment of the tube? Exactly. We attach the tube, anastomosis, which means that they would sew the tube back together to maintain bilateral fertility. But what's the danger here at the level of detail? When that tissue reconnects in the tube, what is the risk, especially on the inside? Exactly, that you would have an annular scar there. Again, we're talking macroscopically because the blastocyst is still essentially the same size as the egg, which is microscopic. And so one ectopic pregnancy resolved could lead to another one, okay? And so even though in theory, it seems like a partial sapingectomy may preserve the woman's fertility intact bilaterally, in practice, it's pretty risky. Okay, so I guess different doctors have different preferences. I don't know if this can be done more benevolently, like cauterizing, sealing, instead of anastomosis with sew, the traditional needle and thread, right? Or cauterizing. Sometimes today they will cauterize, and here on the salpingostomy it shows this diagram. See a little smoke coming out? This is actually a probe. It's an ultrasound probe. At a very high vibration, this probe serves as a scalpel and as glue because the ultrasound is cutting through the tissue at a very, very precise point or place. And as it does that, because of the vibration that it produces, it's also sealing the capillaries. So there's minimal blood loss. It seals the capillaries. It's kind of plastic. Literally, when you take fire to plastic, it will melt it, right? And seal it. So that's what these new probes do. They're used a lot in laparoscopic procedures, right? Which are minimally invasive. But the downside of the salpingostomy is that in trying to preserve the tube, right, because the slit is done longitudinally, in trying to preserve the tube, the procedure itself goes after the embryo directly and will scrape the embryo off the wall and then discard the embryo. So ethically, what's the challenge here? In salpingectomy, the embryo is not attacked directly. It's very obvious that the embryo will die when we pull out that segment of the tube where the embryo is lodged. But the embryo himself or herself is not attacked directly, whereas here it is. And therefore, salpingostomy, at least under principle bioethics, is not justified because it isn't a direct attack on the embryo, all right? And you see here the crucial difference between killing or allowing to die. In the salpingectomy, the embryo is allowed to die, it's going to die. But in salpingostomy, it's actually killing the embryo. So when you think about it, it takes a little bit of thinking it through in detail, but the surgeon who is doing this procedure cannot but desire to scrape off the embryo, you see? And so there's the evil intent there. It's acting directly on the life of that little embryo. So the bottom line, at least from principle bioethics, that's why the means also have to be justified. The removal of the tube with the embryo inside is okay because it's life for life. But only going after the embryo and scraping that embryo out would not be ethically okay because it's interfering directly with the life of the other human there. See? And so that's double effect. It's challenging because clinically, what's the preferred procedure? Salpingectomy, where typically one side, one lateral reproduction is lost, or salpingostomy, where the incision, which is done longitudinally, typically will heal okay, and the fertility is preserved intact, see, bilaterally. So obviously, from the clinical perspective, salpingostomy is more appealing, it's more benevolent for the mother. But in principle of bioethics, we cannot justify because it's going after the embryo directly. And like we said, the effect, the good effect should not flow directly from the evil effect, okay, which in salpingostomy it would. Okay, folks, so again, I've covered a lot here in a brief time, but these are challenging cases. They happen. It's mostly on the women, whether they're pregnant or not, but if they're pregnant, there's another layer of complication involved. However, at the end of the day, this principle of double effect is very, very useful. And typically, it's a question of walking the person through the steps because how many people hear about double effect out there on a regular basis, right? Not a common thing. And that's why I teach it, I take my time with it and do a review so that you can help others along the way whenever a situation like this arises. Yes, Luis, what do you have?
To be clear, if like a very small section of the tube containing the embryo
yes.
is removed surgically, that would make it but it would not make it a salpingostomy.
Correct. It's still a salpingectomy. If you remove any section of the tube, as small as it is.
Looking at it from your perspective here, don't you feel like there's a large degree of similarity in the two, and that both of these would preserve the reproductive viability of the tube, which may end up having been the original problem? I don't know.
It can be.
But they specifically result in the death of the embryo.
Right, but you see, there it is strictly at the ethical and at the philosophical and at the ontological end of things, right?
You're going to see the direct contact.
Exactly.
But I feel like
I know it's getting close, but you know it's not the same thing.
if I don't attack you, but I pick up, this is a
Right,
example, but
right.
I pick up your house with you and then I drop it,
Mm-hmm.
does that not amount to?
Well, it depends. Why are you picking up the house? You see, are you saving the life of somebody?
That is true.
That's the thing. So you got to look at the moral object, you got to look at the intentions, and you got to look at the circumstances. Here we have a life-threatening situation. Obviously, this assumes that the pregnancy did not resolve itself. The pregnancy did not resolve by itself. Now there has to be an intervention, medical intervention. These are the two options, all right? There's actually a third option, which is methotrexate. Methotrexate is a type of chemical that inhibits DNA synthesis, replication on the tissue that is reproducing fastest, right? And what tissue is going to be reproducing fastest is going to be precisely the establishment of the placenta. So using methotrexate on an ectopic pregnancy, what happens is it goes after the placenta of the embryo, what is the placenta for the embryo, ontologically speaking? as a matter of being in itself, what is the placenta? Is it a tissue, organ, system? What is it?
It's like an organ.
It's an organ. It's an organ, right? It's an organ. Now, is it a vital organ or not a vital organ?
It's vital, right?
It's discarded when the baby is born,
But it needs it.
but during the pregnancy, it's vital. So it's the only vital organ that we discard at birth. We don't need it anymore, okay? But during the pregnancy, it's certainly a vital organ. So going after the placenta is essentially going after one of the vital organs of the embryo. So it's tantamount to attacking the entire embryo. It's like going after the heart of the embryo, the lung of the embryo, right? And so that's it. That's why, again, from the principal perspective, that embryo has to be left alone. Otherwise, we're not just allowing the embryo to die, we're actually killing the embryo. That's the challenge right there. It is very, very challenging. But that's the analysis. So another thing that is very important, that is crucial to understand, is that when an ectopic pregnancy happens, by definition, wherever that embryo is lodging, that area, that region is now pathological. It's no longer healthy, all right? Which is kind of challenging because one could ask the question, why did the embryo get stuck there to begin with? Who knows? It's a very detailed question. Maybe there was some scar tissue to begin with. We don't know, but it does happen. And therefore, the region, the tissue where the embryo is lodging, if it's not the uterus, then that tissue is considered pathological because it's the wrong place. The embryo is just in the wrong place of the body. And it's a life-threatening situation. It's not something that is, you know, a mole or something like that. So these are the cases, and they do happen. I wanted to see, because I looked it up before, but I forget, percentage of ectopic pregnancies.
I don't suppose you could conduct a self-endoscopy and then try to
Save the embryo? Well, stop injectomy and try to save the embryo, because the embryo is still intact inside the tube, right? There was, that issue was brought up actually at one point, because is there a duty to try to save the embryo? Now that the tube has been, the pathology is removed, now the woman is safe because the embryo is not growing in the wrong place anymore. Is there a responsibility to try to save that embryo?
What I was trying to get at was, you have a tube now. Is there any means of attempting to induce it to now attach at the correct uteral wall?
Exactly. So specifically, would there be a responsibility to try to reattach that embryo to the uterine wall? Okay, one could say that theoretically there could be that responsibility if we're placing such a high value on the life of the embryo that is as valuable as the mother, for example, and that, after all, that was a wanted pregnancy, right? So the challenge is this: we just don't have the technology to do that yet, all right? Because imagine you're dealing with someone who is really literally microscopic. It's the first week, the first few days, the blastocyst is practically the same size as the egg, maybe twice the diameter in those few days. Remember the hatching that occurs, right? When the embryo crawls out of the zona, the cumulus. So what happens, you're dealing with someone who is so delicate to intervene directly on that embryo, one could damage the embryo. And maybe if it's just a few cells of the blastocyst that are lost, but maybe that's an arm, or maybe that's a heart or something, you know, remember from there, it will go into gastrulation and then the 3 germ layers. So that little tiny embryo is so delicate, just a few dozen cells, that to interfere with that embryo at that point could actually end up worse doing more damage to the embryo. So no, there is no obligation, there's no ethical obligation to try to reattach that embryo into the uterine wall, okay? It's just double effect. It's foreseen, it's tragic because the embryo will die, but at least there was no direct intention to kill the embryo. Yeah, so I wanted to see here. Look at that, I have forgotten, it's so high. 90% of ectopic pregnancy is resolved on their own. It's amazing. That's a good thing, okay? So it's that 10% that causes all the challenges, but about 90%. So this is something good and important for women to recognize the symptoms and so forth. The typical thing is going to be abdominal pain that is different from the other types of pain. And it's something to watch for. Okay, well, so we covered the various reproductive cancers in men and women. Each one has a separate issue. We cannot lump them all together. And like I say, the reproductive cancers have a special ethical quality to them because those organs also belong to the next generation. So there's kind of a double responsibility to maintain them healthy and to not mutilate them without serious reason. But when there's cancer, for sure, we're dealing with the health or the life of the individual, and therefore it's justified. And then the ectopic pregnancy with the various options that one would be correct, the other one not correct. All right, well, we finished a little early today again. No other questions or comments on it? All right, well, we'll stop here then. Let me stop the recording.